Good evening. I am very pleased to welcome you to an ICAP Grand Rounds webinar. We'll be talking today about integrating mental health interventions for HIV prevention and care. If I can, I guess we'll give folks a minute or two to join, and then we'll be starting. So please just stay tuned. All right, I think that we can begin, and I'm sure a few more will join as we get started. So I'm Dr. Jessica Justman. I'm the Senior Technical Director here at ICAP at Columbia. And we can have our next slide. I'm joined by Fatima Tsouris, who is the Deputy Director of Human Resources for Health Development at ICAP, and is also a Senior Technical Advisor for Prevention of Mother-to-Child Transmission. Next slide. And I am here to welcome you. I will be introducing Dr. Collins, and I want to remind everybody, I think everybody's quite familiar with our format, but you can use the chat box if you simply have comments. But if you want questions to Dr. Collins or to any of the panelists, please use the Q&A box. And the webinar recording and the slides will be posted either by the end of today or tomorrow on the ICAP website. Fatima will be moderating our Q&A. So let's now turn to our speaker, who is Dr. Pamela Collins, professor in the Department of Psychiatry and Behavioral Sciences, and also professor in the Department of Global Health at the University of Washington. Dr. Collins is the executive director of ITEC, the International Training and Education Center for Health, also based at the University of Washington. I think many of us know ITEC as a global health implementing center that brings public health interventions to scale in partnership with ministries of health through a global, through a multi-country network. Dr. Collins also directs the University of Washington Consortium for Global Mental Health, which is an interdisciplinary center dedicated to improving the care of people with mental health conditions in low resource settings, locally and globally. I first met Dr. Collins when she was here at Mailman. She received her Master's of Public Health at Mailman and was a faculty member here for over a decade until she left to join NIH, where she was the Associate Director for Special Populations at the National Institute of Mental Health and Director at the Office for Research on Disparities and Global Mental Health and the Office of Rural Mental Health Research. She then moved to the West Coast in 2018 and has been at University of Washington since then. So please join me in welcoming Dr. Collins, and we really look forward to your talk, Pamela.
Wonderful. It's a pleasure to be here. Let me share my screen. Oh, okay. This is telling me it will stop other screen sharing, so that's fine. And okay. Hello, everyone. It's really a pleasure to be here. I'm going to be talking today about integrating mental health and HIV. And I want to start with this question. because it's a question that I think all of us are trying to understand. And this is specifically for the non-mental health specialists in the audience. What is required to successfully identify and treat a mental health condition in the people seeking care where you work? And what, if anything, prevents this from happening? I'd like to come back to this question at the end. As a global community, most of us that work in mental health are trying to answer this question. And my talk will review what we mean by mental health and mental disorder. I'll talk about the relationship between HIV and mental health, and I'll talk about integrating services for mental health and HIV by sharing research findings and by, I think, talking about some of the practical lessons that people are learning as we all work to implement these kinds of services. And I hope to leave enough time at the end for discussion, both to learn about what you're learning, as well as share whatever other insights I can. So first, ensuring that our language is clear as we communicate about mental health is important. Mental health is defined as the capacity of thought, emotion, and behavior that enables every individual to realize their own potential in relation to their developmental stage, to cope with the normal stresses of life, to study or work productively and fruitfully, and to contribute to their community. So that's a broad definition. Mental disorders, on the other hand, and often we're more often focusing on mental disorders when we talk about integrated care, but that doesn't have to be the case. But mental disorders are defined as disturbances of thought, emotion, behavior, and relationships with others that lead to substantial suffering and functional impairment in one or more major life activities. And notably, we don't consider emotional experiences or distress a disorder until there is functional impairment. And what defines a disorder is also very much influenced by cultural norms. I made a note here that the term mental health conditions is also used in place of mental disorder. And sometimes that's because of stigmatizing associations with the term disorder, but also because conditions may encompass things that are less severe than what meets diagnostic criteria to become a disorder. Mental health is increasingly conceptualized along a continuum, from well-being to more specific and even persistent mental health syndromes. So I want to take a moment. You're seeing across this.
Pamela, we're losing some of your audio, so I'm going to suggest that you turn your video off and see if that helps things.
Okay, let me do that.
And maybe just go back to the beginning of this slide.
Okay, 1 second. Okay, can you hear me?
Yep, it's so far so good.
Okay, great. So this slide is really helping us to think about mental health along a continuum. That we tend to think about mental health now as a continuum from our well-being to a progression to well-defined syndromes that can be quite severe at the other end of the continuum. So this graph is showing us increasing severity of symptoms as we go from left to right. But what's important is that everyone falls along this continuum, from well-being and no distress to non-specific mental distress, to the need for perhaps early treatment, and to having a diagnosed disorder and perhaps the need for rehabilitation and ongoing support. So this is the continuum. And I want to ask, why is this important? It's important because it is universal. As I said, we all fall along this continuum, and our location on this continuum shifts, sometimes in the direction of greater symptoms and sometimes in the direction of fewer or no distress. During the COVID-19 pandemic, for example, more members of the communities that most of us or all of us belong to moved toward non-specific distress and some to defined diagnosable syndromes, especially anxiety and depression. The other important aspect of this continuum is that it is It's destigmatizing because everyone belongs on this continuum. There is no us versus them in this case. We all move along this continuum. And finally, importantly, interventions can occur at each stage of this continuum. So at the stage of well-being and no distress, mental health promotion and measures to sustain mental health are most important. As we move into non-specific mental distress, people can take advantage of self-help, calling on support from informal networks, exercising coping strategies, and moving into the need for early treatment where symptoms begin to coalesce. This is where one can seek advice from primary care in settings where primary care providers are equipped to do that, or specialist care, access through primary care. And in this case, we're also saying that, this is where HIV services can be equipped to provide the mental health support that's needed along this continuum. And finally, when there are persistent conditions, the interventions require rehabilitation, ongoing community support, and specialist mental health services. So these conditions are common and they are ubiquitous. We know that about 38 million people around the world live with HIV. More than 1 billion people worldwide are estimated to live with mental or substance use disorders. This is about 15% of the global population. And even if we just look at 15 to 49-year-olds, take that just because that's a span of many people that are seeking HIV care, though notably we have people aging with HIV, so I don't want to leave out that community as well. But again, about 124 million people in this age range live with alcohol and drug use disorders, still close to 15% with mental disorders, and depression, which is probably the most prevalent in the context of HIV, about 4.5% of people, 4% living with depressive disorders globally. So this is everyone. And these are some of the countries where we work and are collaborating with partners to support mental health service delivery in various capacities. So this is quite a range. I show this set of countries because they are geographically diverse. And yet, if you look at the dark purple bars, this represents adolescents. The gold bars represent adults in young adulthood and middle age. And we can see that prevalence of mental health conditions among adolescents ranges from about 12% to 19%. Young adults and older, around 13% to about 18%. There is variation across settings, but the take-home point here is that, again, these are common conditions and they need to be recognized and managed. And why are they so important? They're important for many reasons, but I'm going to jump to, I think, something that we don't often consider when we think about mental health conditions is that the mortality that's associated with these conditions. People with mental disorders have a mortality rate that's twice as high as the general population. And all-cause mortality is elevated for people with psychoses, mood disorders, anxiety disorders. You can see that the mortality is greater for psychoses than the others. But overall, there's about a median of 10 years of life lost from all causes as a result of having a comorbid mental health condition. And this comes from data from a meta-analysis published a few years ago. But this is a surprising number that around 8 million deaths per year are attributed to mental disorders. And these data are, this is again global data, and we see the numbers of the numbers of years of life lost are actually higher in countries with fewer resources. So this is important to note. I also just want to make a note that this was also true in the COVID pandemic. This are data from 61 million patients in the US that reported a recent diagnosis of a mental illness, showing essentially that those with a mental illness had a much greater odds of contracting COVID. And in fact, people with a recent diagnosis of depression or schizophrenia had more than 7 times the odds of people without a mental illness of being infected with COVID, had higher rates of hospitalization, as well as a higher rate of death rate. The death rate, again, from COVID was nearly twice that of people without a mental illness. So these are important conditions to recognize also when we're thinking about how do we save lives and keep people healthy. There are a number of challenges that limit our ability to address mental health needs around the world, and particularly in countries with limited healthcare and mental health care resources. These include the governance gap, where only the plans that fully comply with human rights instruments. There are misplaced priorities with respect to spending. These are data from the World Health Organization, where 2 out of every $3 spent on mental health goes to running psychiatric hospitals rather than providing care in the community. There are resources gaps. Countries spend on average just about 2% of their health budget on mental health. That's on average, so some countries spend much less, some countries spend much more. There's a scarce workforce. In low-income countries, there are fewer than 1 mental health worker per 100,000 people. In many countries, there's a lack of essential medications. In low and middle-income countries in particular, essential psychotropic medications are often unavailable or unaffordable. And there's a digital divide, and this is relevant now because we are finding that digital or e-health, m-health interventions can help to extend access to mental health services. But an insufficient number of specialists is simply one problem. A second challenge is that when we do identify people who have a problem with anxiety, major depression, or substance use disorders, we find that very, very few people receive minimally effective treatment. Around 2% of people in lower middle income countries, when identified with an anxiety disorder, actually receive minimally effective care. You can see these numbers are in the pale blue bars. For major depressive disorder, only about 4% of people receive minimally effective care, and for substance use disorders, 1% receive minimally effective treatment. In high-income countries, the numbers are better, but still not good. For anxiety, only about 14% of people with an anxiety disorder in a place like Seattle are likely to get minimally effective treatment. Only about 1 in 5 people with major depression and only 10% of people with substance use disorders in high-income countries are likely to receive effective care. So we have an issue both with access to care, with provider availability, and with ensuring quality. So integration of care can help to, the hope is that integrated care can actually help to ameliorate some of these situations. But let's talk about why integrate services. And I'll start by talking about the relationship between HIV infection and mental health. As we know, that there are shared determinants of mental health and of HIV acquisition. Those start with age and gender, sexual orientation, ethnicity in some settings. Some of those biological determinants are pre-existing illnesses or infections, as well as maternal health status. Cognitive and behavioral determinants include low self-esteem, impulsivity, substance abuse, transactional sex, and social and environmental shared determinants can include low socioeconomic status, adverse life events, including coercive sexual encounters or interpersonal violence, social marginalization and exclusion, stigma and discrimination, and abusive institutional environments, abusive institutionalization. So the relationship between HIV and mental health is bidirectional, such that people with HIV have a greater risk of mental health conditions, and people with existing mental health conditions have a greater vulnerability to HIV infection. Comorbidity and increased risk then can lead to chronic disease consequences. So high prevalence of both conditions, high disease burden, higher mortality, as we just talked about, as well as social and economic impacts such as reduced productivity, impoverishment, and simply a large unmet need. Integrated responses, as you can see on the right side of this slide, including screening for mental health problems in the context of HIV care, or screening for HIV in the context of mental health care, should guide us to treatment. We know that we have effective psychological as well as pharmacologic interventions that can be delivered both in HIV care and treatment settings. When this happens, these can decrease risk, and that decreased risk pertains to reducing risk behavior, improving adherence to prevention, treatment, and care, as well as linkage and retention in care. I'm going to talk just briefly about HIV among people with existing mental illnesses. This is often disregarded by the health systems, but the sexual and relationship health of people living with a serious mental illness is important. And in many countries, the prevalence of HIV infection is significantly higher than the general population. This is particularly true in settings without a generalized HIV epidemic. You can see that the prevalence estimates for North America, Europe, Africa, Central and South America, and Asia on this table. Prevalence tends to approximate, but sometimes exceed the population prevalence where the HIV epidemic is generalized, that is greater than 1% of the general population. And this is a study from Uganda looking at HIV prevalence of women in particular, showing that HIV prevalence of women with mental illnesses is higher than the prevalence among women in the general population, 14% versus 8%. And a study from Botswana among hospitalized people with mental illness, looking at HIV prevalence of 31%. And again, looking at women in particular, HIV prevalence among hospitalized women with a mental illness was 53%, whereas HIV prevalence among women in the general population is 38%, and much lower among men. And this is a pattern that we see in the prevalence of HIV more generally, but also with this intersection of mental illness and HIV, this higher prevalence among women is often seen. So, depression, as I mentioned earlier, is one of the more commonly occurring conditions among people living with HIV. And estimates in North America are that people living with HIV have a prevalence of depression ranging from 32 to 42%. Data from India and China has higher prevalence estimates, 59 to 61% in a few studies. And the recent meta-analysis showed estimates for sub-Saharan Africa are around 24% of people with HIV live with depression. And what are some of the predictors of depression in these data? Female gender, older age, unemployed, HIV-related physical symptoms, low CD4 counts, impaired function, and poor social support. And the consequences of depression and HIV include barriers to HIV testing, poor adherence to care, greater attrition from care, and higher mortality. I'm going to show you two slides that look at the data on mortality. This first one is data that Brian Pence reported from a sample of people in the United States, really showing that longer exposure to depressive symptoms yields worse HIV care outcomes and, in fact, greater mortality. So this is showing that among nearly 6,000 US individuals living with HIV, every 25% increase in the percentage of days with depression led to a 19% increase in risk of mortality. We have new data from four African countries that show similar trends, and I'll show you that slide. These are data from people living with HIV in Kenya, Tanzania, Uganda, and Nigeria in the African cohort study. In this case, our sample included 2,500 eligible participants the data was followed for 7 years. A majority of these were women. Median age was 38. More than half were virally suppressed, and about 18% of this group had possible depression as measured by a CES depression score greater than or equal to 16. And in this study, we found that for every 25% increase in exposure to depressive symptoms, was associated with, or the percent of days lived with depression was associated with a 69% increase in the risk of all-cause mortality. So again, it's important to recognize depression, important to treat it, because it tends to make all conditions worse. So in summary, why do we want to integrate mental health care? Because the prevalence and burden of mental health conditions are high globally. Mental and physical health problems are interwoven. Co-occurring mental health conditions increase morbidity and mortality. The treatment gap for mental health conditions is quite large. The access to effective and adequate treatment is challenging all around the world. Primary care for mental health enhances access. Primary care for mental health generates good health outcomes, and where one can integrate HIV and mental health services into primary care, we would anticipate that we would see the benefits of that integration. Okay, and importantly, integrated health services also have principles that support equity. Integrated care ideally centers human rights and access to justice, takes a life course approach, leads to the empowerment of people living with HIV and people with mental health conditions, involves a multi-sectoral approach to address the social determinants that are driving risk for both HIV and mental health conditions, engages people in people-centered services and care, and provides access, of course, to quality health services and support. So for these reasons, we've seen a steady global push for integrating mental health into HIV. In 2018, UNAIDS held its first program coordinating board meeting focused on mental health and HIV. Shortly thereafter, we saw the new 2025 UNAIDS HIV targets, which now incorporated the need to address stigma and discrimination, to address social and structural conditions increasing risk for HIV, but also importantly, really provided a target for integrating services, that 90% of people living with HIV and people at risk are linked to other integrated health services, including care for mental health. And finally, just this year, we released the UNAIDS Integration of Mental Health and HIV Interventions manual with key considerations, providing some real guidance for how one can do this in a variety of settings. And of course, finally, integration is also consistent with the push for universal health coverage, where services should be integrated and focus on the needs of people and communities, and services are reoriented to ensure that care is provided in the most appropriate setting. The good news is that we also have a strong evidence base for using task shifting to deliver mental health interventions around the world. That evidence base has grown considerably over the last 15 years, simply showing that a variety of providers are capable of delivering evidence-based mental health interventions in Africa, Asia, Latin America, North America, all around the world. And we have a growing evidence base for the integration of mental health services into HIV in multiple countries. A lot of this evidence is coming from Africa, but we still have a lot to learn about sustainable implementation of these interventions. But I want to just highlight a few that are on this particular slide. The very recently published peer-facilitated psychological group intervention for perinatal women living with HIV and depression in Tanzania. The Healthy Options study was published and showed that a community-based health worker could deliver a problem-solving therapy intervention to perinatal women, and women who received the intervention had reduced depressive symptoms 6 weeks postpartum. They were hoping to see effects at 9 months postpartum, but did not, but the effects were quite strong at 6 weeks postpartum. Recently, I think the first large study of an adolescent-focused intervention in Africa was published in Zimbabwe. with the Zvandiri project, showing that peer-led counseling with a problem discussion, also a problem-solving approach again here for adolescents, led to reduction in depressive symptoms as well. And finally, Ethel Nakimuli and Pungu's group support psychotherapy has shown effectiveness and cost effectiveness for people living with HIV in Uganda, and that all of these have been administered by non-specialists who've been trained to deliver the intervention. And the last one shown on this slide is just the study of the original Friendship Bench trial in Zimbabwe, which included people with and without HIV. But of course, we know the Friendship Bench is now being utilized for intervention in many countries. And certainly the adolescent trial in Zimbabwe was an adaptation of the Friendship Bench for a younger population. So integrating HIV and mental health services requires considering the structure of care. Will integration happen through co-location, this level 1, where we have clinical and community integration of services? Will it happen through integrated provider networks, which is level 2 on this diagram? Or will service delivery systems fully integrate services at the health systems level? So we have many options when we talk about what integration can look like. And this is just an example of what level 1 clinical and community integration could look like. One might have integrated care using care managers that are nurse-led or social worker-led, for example, or even community using another non-specialist provider. A non-physician in this case coordinates care and develops integrated HIV, mental health, substance use care plans, and facilitates referrals. And this is similar to what the collaborative care model looks like. So let's talk about strategies for integrating mental health into HIV care. First, what needs to be integrated? Well, care for conditions that commonly occur in HIV need to be integrated. Depression, anxiety, trauma, and management of alcohol use disorders are places to start to consider. Treatments include psychological therapies and medications. I'm going to focus on psychological therapies here because the medications really depend on what's in formularies and what's available more locally. But psychological interventions can be delivered by non-specialists with adequate support and supervision. And this next slide shows you a long list of evidence-based psychological interventions that are recommended for depression, for substance use conditions. I'm not going to go through all of these. Many of these can be found in the ICAP manual or in the UNAIDS guidance document that I mentioned. But it's important to recognize that we have a number of these, and many of these have been adapted into scalable interventions that can be delivered by providers with more abbreviated training. And these interventions for scalable psychological treatments are modified so that we can simplify their implementation while maintaining the active components of the intervention. A question people often ask is, how do these treatments work cross-culturally? Because many of these are developed in high-income countries and adapted for low-income, lower and other cultural contexts. What's not yet known and what has not been explored much is whether the kinds of explanatory models of depression that these evidence-based treatments that originate in a different cultural context, are they applicable cross-culturally? And I think one of the most consistent findings when we look at mental health interventions is that cognitive behavioral therapies are effective cross-culturally, but do we really understand what aspects are the same constructs most important in different settings? So this was a really nice study from South Africa that asked, what are the cognitive or behavioral constructs most important for understanding and treating depression among people living with HIV in South Africa? And the researchers looked at two constructs, at rumination or thinking too much as one of the cognitive constructs for depression, and behavioral avoidance, and the opposite of that, which is behavioral activation, for the behavioral component of treatment. And what their study found, I'm going to give you a highly summarized version of the outcome, which was that they found that behavioral activation was associated with reduction of depressive symptoms, improved quality of life, reduced functional impairment in the South African sample of people living with HIV, which simply, number one, it confirms the fact that, yes, these constructs are relevant cross-culturally. And in this particular study, really also reemphasizes the fact that behavioral activation may be of particular treatment value in this context. A recent narrative review of mental health interventions in low and middle income countries was published that examined both psychological and pharmacological interventions. The psychological interventions that were part of that review are listed here: cognitive behavioral therapy-based interventions, problem-solving therapy, psychosocial support groups, mindfulness-based interventions, rational emotive behavioral therapy for alcohol use problems, and brief alcohol interventions. And what they found about these different interventions was that significant intervention effects were associated with having a lower caseload per provider for psychological interventions. So when we ask people to deliver psychological interventions, ensuring that they aren't overloaded with cases, this was actually a significant predictor of intervention effect. What they also found was that the approach used, whether these were individual sessions or group sessions, and provider qualifications, whether these were specialists or non-specialists, were not actually associated with intervention effectiveness in this sample of studies. Adherence to treatment was associated with significant treatment effects, so ensuring that people actually came to care, but that relationship in the end did not actually achieve statistical significance. But these are the kinds of things that we often wonder about. What are the qualifications of the provider? How was the intervention delivered? What are the number of treatment sessions? How many treatment sessions did the person attend? And then finally, what are the active ingredients? So in this analysis of studies, caseload for provider turned out to be the most significant. We also found that active ingredients of interventions mattered. And this is a list of active ingredients of many different kinds of psychological interventions, particularly the ones that we listed in the previous screen. The ones in purple are those that were associated with intervention effectiveness. So venting, that is sharing personal problems, having the chance to share what the problems are, social support, coping skills, cognitive restructuring, and behavioral activation were associated with intervention effectiveness. And they found that studies with significant effects were more likely to have 3 or more active ingredients, so a combination of active ingredients in the intervention that's delivered. So, integrating care, once we've established what we're going to integrate and what those interventions look like, requires planning. And this planning begins with assessment of the goals and functions and resources of the HIV program that will receive the mental health services. So one has to know the existing knowledge and skills of the healthcare providers that are expected to deliver these interventions. Can they identify common mental health problems? Do they know when to refer? Are they motivated to build new skills? How do they perceive the benefits of these new skills? Do providers view these skills as helpful for their primary responsibilities? All of these are things that need to be assessed at the start of planning integration. Are there adequate human and financial resources? And the two kinds of services, HIV and mental health services, need to talk to each other and should identify shared and achievable objectives. So this includes conducting joint assessment of needs and feasibility for integration, identifying the exact tasks for healthcare workers, and specifying the training, support, and supervision for healthcare workers and clinicians to provide services. And finally, assigning those responsibilities and establishing a monitoring mechanism. So this means assigning responsibilities to healthcare providers and to managers of the, in this case, HIV program, and to the mental health team. So how do you prepare? First, we look at what are the tasks and what are the specific human resources. Most of you are probably familiar with the MHGAP Intervention Guide and Operations Manual from WHO, which describes how to deliver evidence-based care for mental, neurological, and substance use disorders. So managers have to determine which providers will develop which complementary skill sets in order to deliver the elements of these interventions and manage a range of mental health problems. So there's a decision-making process here. And continuing along with tasks and human resources, after making those decisions, then we have to specify the skill sets that are available. Who will actually carry out these tasks? Who will do the screening, the engagement of patients, the education of patients and family members? Who will do the close follow-up and tracking of adherence and clinical outcomes? Who does the targeted evidence-based psychological interventions? Who will provide the pharmacologic treatment? Who will track population-based outcomes and quality improvement approaches? And who provides specialist supervision and consultation? And finally, from preparation to provision of services, services should be provided in facilities that are coordinated and holistic, that are able to manage both physical and mental health care. And we need a multi-level approach to provide integrated care that focuses on, in addition to the symptoms, to the broader social determinants of health that people are showing up to clinic trying to address. Social support and stigma reduction are also important elements of integrating care. And finally, monitoring and evaluation is critical. So developing and applying a framework for monitoring and evaluation progress and outcomes is a key part of integrating services. So the integrated care package needs to be standardized if it's going to be scaled up. And evidence-based models for these kinds of integrated mental health care packages exist. The collaborative care model is probably the most researched example. And there are wonderful examples of this team-based approach to care in many different contexts. But I think one of the probably well-studied ones is the example from South Africa and University of KwaZulu-Natal and the Schmidt study, which examined the adaptation of the collaborative care model for integrating HIV care into primary care as well. So effective development and implementation of integrated care requires ongoing iterative adaptation, hypothesis testing, figuring out what's going well, what's not going well, how do we adjust, how do we do performance data monitoring in order to improve service outcomes. So I'm going to talk for a few minutes about HIV prevention and mental health, and then we'll try to wrap up pretty soon. So when we looked at that continuum of the mental health care continuum to well-being all the way to severe illness, an important part of that continuum is maintaining good mental health or so preventing poor mental health, but also, of course, preventing HIV is an important part of integration. So integrated care can think about both prevention of mental health problems, but also integrated care is important across the HIV care continuum from prevention to treatment and everything everything in the middle. So what do we know about the relationship between mental health and HIV prevention or risk behaviors? And what do we know about interventions that address mental health in the context of HIV prevention? We conducted a review of literature and published this just about a year ago that examined the relationship between mental health related symptoms and HIV prevention behaviors. And the high level outcomes of that review showed that for the most part, having more symptoms of a mental health condition lead to poorer HIV prevention behaviors. So with respect to PrEP adherence, more depressive symptoms were associated with worse PrEP adherence in a group of studies over the last 5 years. People were more likely to have HIV testing when they had fewer mental health related symptoms, and inconsistent condom use or condom efficacy was associated with more symptoms of depression or PTSD generally. So there are exceptions to these rules, but overall, the direction is that you're more likely to have better, effective HIV prevention when you have fewer mental health problems. What works for HIV prevention and improving mental health? Well, we found that at the systems level, effective linkages between services were very important. So HIV testing in the community, having a linkage to mental health services, as well as linkages to legal and other services. Involving trusted community organizations in this linkage of services, and having a robust peer network that can actually help to link people to care was important. At the individual level, we found that evidence-based psychological interventions were most effective in reducing symptoms of mental health problems in the context of HIV prevention. And those tended to be cognitive behavioral therapy approaches. And we found that similarly, these kinds of theory-driven HIV risk reduction interventions were also most effective. So this combination was effective. We found that structural intervention showed promise. So cash transfers led to fewer depressive symptoms for boys and delayed sexual debut for boys and girls. And getting girls access to education also has some promise for both HIV prevention and for and is related to mental health, mental well-being. So I think we're at a very exciting time that for integrating HIV and mental health interventions, we now have global AIDS targets that actually call for this, that call for the linkage to mental health services for 90% of people at high risk of HIV or living with HIV. These call for a reduction in punitive laws and policies, stigma and discrimination, gender inequality and violence. It means that one of our goals has to be to optimize social interventions that can reduce HIV risk as well as risk for mental health conditions. We also have to address some of these considerations when integrating treatment for HIV and mental health conditions. We have to ensure that there is contextual adaptation of the interventions. We have to address the need for human resources, and task sharing can help. We also recognize that in our learning from the data from multiple pilot trials as well as larger studies, which have contributed to our understanding of integrating mental health interventions, that if effectiveness is linked to fewer providers, we need more of them. So in most countries, task sharing can help, and having cadres of providers with more abbreviated training to deliver services is feasible. Lay providers can sometimes even be more acceptable for certain communities. We need to have a better understanding of what is the frequency of visits that makes the most sense in HIV care, and how do we reduce attrition. The schedule of HIV treatment visits and the schedule of visits for managing a mental health condition are often don't necessarily coincide. Mental health treatments tend to be weekly kinds of interventions, but I think many of you are probably in places where you're experimenting with even monthly interactions for mental health to see if that works. We need more data on the frequency of visits and the best ways to reduce attrition. We need to be able to map out referral pathways for stepped care. So when the intervention for less severe symptoms is not sufficient, what's the next level of care? And are the referral pathways clear? And are the referral pathways reliable? We also need to build in coaching and supervision when we're implementing mental health in the context of HIV. The providers that are delivering these services need coaching in order to maintain quality of the care that they are delivering. And coaching and supervision also help to provide emotional support for providers who are managing mental health conditions. Medications have to be available. Antidepressant medications have to be available, and we need to ensure that formularies have those. And finally, we need to adapt health information systems so that mental health data can be incorporated into the health information system, which may make it more likely for providers to be able to document these things and to help to ensure that the implementation occurs. So action steps for integrated intervention also include identifying community partners and leaders for co-design, delivery, and linkage of HIV and mental health resources. We need to facilitate the integration of sexual health promotion into mental health care settings as well. I want to emphasize, I've talked mostly about people living with HIV and the need for mental health care in that direction, but we also need to resume studies to promote sexual health and HIV prevention for people with severe mental illnesses, recognizing that establishing intimacy and options for consensual sexuality is a part of recovery from severe illness. And finally, I just want to remind everyone that this document is out and is available online. I was a part of putting this document together, and I think all of us who are involved in this at UNAIDS and elsewhere would be interested to see how this is helpful and how it can be helpful for achieving this goal of integrating mental health and HIV. And with that, I'm going to stop sharing, and I'm going to hopefully turn on my camera without causing my sound to go away and see if there are questions.
Great, thanks, Pam. Can you hear me?
I can hear you.
Perfect. So we do have a few questions that have come in, and I'm glad that you highlighted in your presentation the UNAIDS targets. I think the other piece that's quite critical in many of the countries that are online today is the importance of mental health integration in the new Global Fund application process that countries are going to be responding to. And that is a main feature of the Global Fund request for proposal. So I think this is a timely topic that countries need to be considering mental health integration. So just, there are some questions in the Q&A for you. The first question is if CETA, so the Common Elements treatment approach, has been mentioned as an evidence-based intervention for low, middle income countries. I'm not sure if you mentioned that in your presentation.
Yeah, thank you. That was on that long list of interventions in the orange square. But yes, the Common Elements treatment approach is one of the evidence-based interventions that, of course, was specifically developed for work in low and middle income countries. And people are using it in HIV care. In fact, our team in Mozambique at ICAP is implementing CETA, or CETA Mozambique, as we call it, which is, it's been adapted to that particular context. And there have been some evaluations of it. I think I can say that the very first kind of brief evaluation that Brad Wagner at UW did with colleagues working with Health Alliance International and with ITEC in Mozambique was a pilot study showing that actually CETA was very effective in reducing depressive symptoms, completely reducing suicidality in a sample. And this was really a convenient sample, and this was not a randomized trial or anything, but it examined, but I think it showed such promise that there was from after the first month of CETA, they saw a 9% increase in adherence. After 3 months of CETA, they saw a 19% increase in adherence to HIV care, reductions in suicidality, and reductions in depression. And that is now being scaled up. And there may be other CETA HIV evaluations that some of you in the audience may know of, but that's one example of a brief intervention. We certainly need bigger studies that are following those outcomes for longer and that are more rigorously designed.
Great. And then another question from one of the participants is around ART drugs and mental disorders. How well are HIV programs monitoring the two? Is there a need to be worried as some ART drugs are associated to cause mental health disorders, or is this a myth?
Yeah, that's a great question. And first of all, that's not a myth. We know that efavirenz in particular is probably the one that's been most studied, where people have had a variety of mental health symptoms related to efavirenz use. I think the new formulation is actually better and people don't have as many side effects with that one. But how much are people monitoring? I think that's a great question. And that's probably a question to hear from some of the clinicians that are on this call in terms of, is that something that people typically, are people asking questions when you are prescribing ARTs? Are you doing a routine assessment of whether people are having strange dreams? Are they having more depressive symptoms? Are they experiencing sleep disturbance? What are the kinds of symptoms that might be neuropsychological that people experience? But I think efavirenz is the best known ART that was responsible for more psychiatric symptoms. And like I said, the newer preparation I think has fewer of those side effects.
So another question is just in terms of task shifting, and if you're aware of any ready-to-use guide or curriculum to train primary care doctors and basic health staff, as well as community workers, to adapt in other countries, specifically in Asian countries. So I think you spoke a bit about the African context.
And so the question is training people to do task shifting or training in specific interventions. Let me first mention that the WHO website, I mentioned these scalable psychological interventions, meaning those interventions, taking a cognitive behavioral therapy and simplifying it so that it's easier to be delivered by a non-specialist provider who has a fairly brief training, period of training. Well, WHO has several of these that are available on the website. It provides the manuals and the details for how do you train someone. And those have been tested in many countries, not simply African countries. The Thinking Healthy program, for example, which has been used for perinatal depression. Actually, the initial trial of that was in South Asia and is now being used in other contexts. That is a manual that you can go to the WHO website and download. Problem Management Plus is another problem-solving approach that is also has been adapted to a scalable psychological intervention that's available on the WHO website. And interpersonal psychotherapy as well has also been made one of those available psychological interventions that you can actually download. And those do provide a comprehensive guidance for how you train and how you deliver those. So I would start there. And then a part of that process of taking any of these interventions is going to involve what are the adaptations that you need to do in your specific context. But these guides also help to walk you through how might you recognize those and what are the kinds of assessment that you need to do. So WHO actually has a lot of resources.
Yeah, and Pamela, would you say that the WHO website also has screening tools available or standardized screening tools that can be adapted and used in local?
So that's a really great question. And that's actually something that I didn't talk about, which I should have. So MHGAP actually does not provide screening tools because they tend to emphasize full assessment as opposed to screening. I think the good news is that there are many screening tools that, over the last decade have been validated in a lot of settings. The Patient Health Questionnaire 9 items, or the PHQ-9, is one that is commonly used to assess depression. The briefer version, the PHQ-2, has been validated in many different countries. That's one I think that is commonly used in HIV care and treatment. Zimbabwe uses the Shona symptom scale, which is its own culturally adapted assessment for screening. So there are a number of these. You can, where do you find those? That's a really good question. You can find PHQ-9 is another one that you can find online fairly easily to download. And if you go to the UNAIDS guide that I mentioned, we list in the appendix a number of those screening tools and where you can find them, and a little bit of a summary about how they're typically used.
Great. Well, thank you so much, Pamela. I think I see that we're at the top of the hour, so I think we need to end, even though this is such a wonderful and vigorous conversation. A reminder that the webinar recording and slides will be posted on the ICAP website. At this point, we do not have French versions of these recordings, just in response to one of the questions, but this is something that we can look into. So thank you for that comment. And wanted to just let folks know that later at the end of this month, Monday, January 30th at 9 a.m., we will have a talk from Dr. Sinead Delaney on introducing, scaling up, and evaluating virus vaccination programs for cervical cancer prevention in low and middle income countries. So please put that on your calendar. And the other talk that's coming up next month, Tuesday, February 21st, again at 9 a.m., will be a talk from Dr. Moore-Newman from the World Health Organization. So thank you so much, Dr. Collins. We really appreciated this talk. I think we'll make sure to forward all the Q&A questions to you, just at least so you have it for your future reference, and folks can then look for the slides that we post on the ICAP website.
Great. Thank you so much. Real pleasure to be here. Have a good day, everyone.
Thank you.
Bye.